Hey everyone, so we are Group 8 from BSMLS 3A5 with a case study of a 17-year-old girl who was observed and tested to have the type 1 hereditary angioedema. So let's go over what hereditary angioedema is. Hereditary angioedema, from the root words angio meaning relating to blood vessels and edema meaning swelling, is a rare inherited disorder characterized by recurrent episodes of the accumulation of fluids outside of the blood vessels, blocking the normal flow of blood or lymphatic fluid, causing rapid swelling of tissues in the hands, feet, limbs, face, intestinal tract, or even the airway. So as you can see here, no swellings could be from different parts of the body of certain patients. People with hereditary angioedema either have a low level of an important protein called C1 esterase inhibitor or C1-INH in their blood, or this C1-INH proteins does not function appropriately. There are actually two main types for hereditary angioedema. Type 1, which is the most common type, is characterized by a lack of C1 inhibitor, which affects 80 to 85% of patients, and the type 2, which is characterized by a dysfunction of the C1 inhibitor, which affects 15 to 20% of patients. Hereditary angioedema can be difficult to diagnose because its symptoms overlap with allergic reactions and common gastrointestinal illnesses, which includes gastroenteritis, irritable bowel syndrome, appendicitis, diverticulitis, and pancreatitis. So, untreated HAE attacks or hereditary angioedema attacks can disrupt one's daily life, so it really is important to recognize HAE symptoms. These symptoms can even be life-threatening if, for example, throat inflammation closes your airway. Some HAE attacks will start with early warning symptoms several hours before swelling begins. These symptoms may include painless, non-itchy rash, tingling skin, skin tightness, fatigue, irritability, sudden mood changes, and even anxiety. During an HAE attack, swelling can happen in a variety of places, as what I have shown you a moment ago. It could be abdominal swelling, your swelling of your extremities, or if throat swelling, it is already a medical emergency, so you should seek treatment at the first sign of this symptom. Tiredness, diarrhea, nausea, and difficulty swallowing and breathing could also be symptoms of hereditary angioedema.
Laboratory investigations for the first lab test includes complete blood count, CBC, serum electrolyte test, serum creatinine test, urine test, and radiological investigations. For the CBC test, hemoglobin and white cell count were both in normal range. In addition, all the serum tests, the sodium potassium chloride creatinine, and as well as the urine test for urine microscopy are in the normal range. And for the pregnancy test, it is negative. So the management of pregnancy in patients with HAE is often a clinical challenge owing to potential worsening of the disease in relation to the physiological increase in estrogens and the limited treatment options. However, in radiological investigations, enlargement of small bowel loops was seen in plain abdominal X-ray. Thickening of the jejunal and the ileal walls with mucosal edema and narrowing of the bowel lumen were reported in her abdominal X-ray after barium swallow. So if a patient is suffering from an abdominal episode of HAE, diagnosis is challenging, as the abdominal examination during acute attacks may be nonspecific with diffuse abdominal tenderness on palpation, hyper or hypoactive bowel sounds, and shifting dullness. Radiographs and conventional barium studies may demonstrate thumb printing due to bowel wall thickening in HAE, and bowel lumen narrowing or bowel distension can be present, although these scans may also display results nonspecific to angioedema. As for the second investigation of Angela's laboratory test includes blood tests, complete blood counts with differential test, serum immunoglobulin test, allergy test, serum albumin test, serum electrolyte test, serum creatinine test, hereditary angioedema panel for serum complement test, and radiological investigation for the chest X-ray. For the CBC test, hemoglobin and the white cell count were in normal range. As for the differential test, neutrophils were normal, eosinophils were low, while the total lymphocytes were high. The serum immunoglobulins were all normal. The serum immunoglobulin tests are used for the evaluation of the antibody, humoral immunodeficiencies, and then the allergy test should be noted. The skin prick test to a variety of common allergens resulted in no positive reels. Rust test or radioallergosorbent test is negative. The serum albumin is normal. The serum creatinine is also normal. As for the serum complement test, which is one of the most important tests, C1q and C3 were normal. C2 and the C4 were both low, so to confirm an HAE diagnosis, laboratory testing is necessary. Patients should have serum levels of C4 measured because levels are invariably low, with C4 less than 30% mean normal level in patients with HAE who have not yet been treated. C4 levels are decreased during attacks and typically remain low between attacks. Lastly, radiological investigation of chest X-ray was required and the result was normal. The low levels of C4 with less than 30% makes us suspect angioedema. Normal levels of C1q suggest a hereditary angioedema, but if levels are too low, it suggests an acquired angioedema. Low levels of C1-INH, which is less than 30% in tube determination space at least 1 month, in a hereditary angioedema suggests we have a hereditary angioedema type 1. Laboratory studies that include both biochemical and genetic testing for families with known C1-INH pathogenic variants are recommended. Patients with clinical manifestations of HAE should first have biochemical evaluation of components of complement pathways with C4 and then the C1-INH. Biochemical abnormalities confirm the diagnosis of the C1-INH HAE. Genetic testing provides confirmation of the diagnosis on the molecular level, which allows testing of asymptomatic members of the family. Preconception and prenatal testing for families with a known C1-INH pathogenic variant are possible. Importantly, a negative test result cannot be used to exclude the diagnosis because HAE is a highly heterogeneous genetic disease and new mutations that have not been previously identified are possible. Similarly, a positive test result may be consistent within the diagnosis but cannot predict the natural history of the disease because the same genotypes may have variable clinical presentations. Genetic testing may be useful. Until now, there is no further laboratory test which could confirm the diagnosis of HAE type 3 and for the sporadic non-familial cases.
My part is about the clinical hypothesis or impression of hereditary angioedema. In the first laboratory result, as discussed by my groupmate Ms. Ninya, in the plain abdominal X-ray, there is an enlargement of small bowel loops manifested, while in the abdominal X-ray, there is thickening of the jejunal and ileal walls with mucosal oedema and narrowing of the bowel lumen after a barium swallow. The laboratory results show why the patient experiences abdominal pain, vomiting, and anorexia. Hereditary angioedema's early warning signs are painless, non-itchy rash, fatigue, skin tingling, and tightness. While in the second laboratory result, low eosinophils and total lymphocytes indicate an allergy reaction and an infection since there are not enough white blood cells produced in the body to fight foreign substances. Sodium and chloride were a bit high, which means there is a medical condition in the body. C1, C2, and C4 were low. The reason for this is thought to be that the complement deficiency leads to an inability to clear circulating immune complexes. This is the reason why the patient experienced abdominal pain and vomiting, but it had subsided and was followed by a diarrhea. The swelling of her lips worsened and tongue following dental extraction. The laryngeal swelling precipitated respiratory obstruction, which required immediate intubation. Therefore, the patient is experiencing type 1 hereditary angioedema.
So I will be discussing about the pathophysiology of hereditary angioedema. Hereditary angioedema, or HAE, is an autosomal dominant disease, which means that this condition is hereditary and is passed to the offspring by a probability of 50%. The disease occurs when there is mutation in one of the two alleles, thus affecting the mRNA transcription and the protein secretion. When mutations happen in C1 inhibitor, the protein structure is being disrupted. This thus lowers C1 inhibitor plasma levels by 10 to 30% than normal. Now, why is this a concern? It's because C1 esterase inhibitor is normally involved in inhibiting kallikrein and stopping the unnecessary production of bradykinin. It is a pro-inflammatory mediator. So in type 1 hereditary angioedema, as diagnosed in this case, there is quantitative deficiency of C1 inhibitor. Kallikrein is left uninhibited, leading to the higher production of bradykinin. This increases vessel permeability and vasodilation, hypotension, bronchial constriction, dry cough, and localized subcutaneous or submucosal angioedema. Minor local trauma, stress, and other events may trigger angioedema. Unfortunately, the molecular events that trigger angioedema remain unclear, and it is also unknown why there is extreme variability in symptom recurrences among patients. It is however clear that the main cause of hereditary angioedema is the lack of the quantity or the function of C1 INH or the increase of bradykinin.
Question 1. What are the functions of C1 inhibitor? The genetic deficiency of the C1 inhibitor is responsible for hereditary angioedema. The SERPIN1 or SERPIN family G member 1 gene provides instructions for making a protein called C1 inhibitor, which is a type of a serine protease inhibitor, or SERPIN, that controls different proteases involved in the complement, kinin or contact, fibrinolytic, and coagulation system. C1 inhibitor is important for controlling a range of processes involved in maintaining blood vessels, including inflammation. Inflammation is a normal body response to infection, irritation, or other injury. C1 inhibitor blocks the activity of several proteins in the blood, including plasma kallikrein and the activated form of factor 12. These two proteins are involved in the production of bradykinin, which is a protein that promotes inflammation by increasing the permeability of the blood vessel walls, allowing fluids to leak into body tissues. C1 inhibitor attaches or binds to plasma kallikrein and factor 12, which prevents them from completing any further reactions. These proteins are cleared from the bloodstream once they are bound to C1 inhibitors.
Etiology and pathogenesis of HAE. Hereditary angioedema, an autosomal dominant characteristic that is caused by a genetic shortage of the C1 inhibitor. It is a condition that affects the person's ability to function normally. The C1 inhibitor gene has more than 200 point mutations that have been linked to HAE. Patients with this condition have recurrent angioedema, which is caused by bradykinin produced as a result of contact system activation. It is brought on by a rapid rise in the permeability of post-capillary venules and submucosal or subcutaneous capillaries, together with localized plasma extravasation. Other vasoactive chemicals may also play a role in angioedema causes. However, the majority of them depend on the release of histamine or bradykinin.
How does hereditary angioedema compare to the acquired forms of the disease? There are two primary kinds of hereditary angioedema. Type 1, which affects 80 to 85% and is characterized by a lack of the C1 inhibitor, and type 2, which affects 15 to 20% of patients and is characterized by a dysfunction of the C1 inhibitor. It is autosomal dominant in inheritance. Typically, clinical manifestation occurs in childhood or adolescence. Normal C1 inhibitor levels are a rare feature of type 3 hereditary angioedema. This form of hereditary edema affects mostly women, which its incidence is unclear. Contrarily, acquired C1 inhibitor deficiency can occur when complement is metabolized in neoplastic diseases such as B-cell lymphoma or immune complex illnesses. Monoclonal gammopathy results in the production of C1 inhibitor autoantibody. When patients have an accompanying condition, the clinical presentation occurs more frequently in elderly people. Attacks can be triggered by minor trauma such as dental work or tongue piercing, viral illnesses, exposure to cold weather, pregnancy, or consumption of specific foods in all types of inherited and acquired angioedema. Emotional stress may also make angioedema worse. Nevertheless, both acquired angioedema and hereditary angioedema can both be fatal.
Moving on to the available treatments for hereditary angioedema, well, unfortunately, there is no cure for hereditary angioedema, but prevention from attacks and treatment of its symptoms can be managed through medication. As stated by the U.S. Hereditary Angioedema Association, medications to treat HAE include Berinert, Zinryze, Haegarda, Ruconest, Firazyr, Kalbitor, and Takhzyro. Antihistamines, steroids, and epinephrine are deemed ineffective because HAE is not hypersensitivity. Since the patient is diagnosed with type 1 hereditary angioedema, which means her C1-INH is deficient, abortive therapy such as C1-INH protein infusion can be used to treat the patient during acute attack. The patient also exhibited laryngeal swelling, thus she was immediately intubated. So in these cases where there is a risk for asphyxia, nasotracheal intubation is performed to counteract such symptoms. Racemic epinephrine may also be given to secure the airway. Aside from abortive therapy, there is also prophylactic therapy done to prevent attacks, such as C1-INH protein infusion, fresh frozen plasma, and medications like Danazol.